a warm welcome to all our Shankar Nethralaya alumni, our speaker, moderators, and distinguished panel members, and all who are planning and joining us today for this virtual meeting. Today is a special day for us because it happens to be our chief's birthday, 84th birthday. We are celebrating the birth anniversary of Chief, our guru and mentor. We are also unveiling a bust of our chief in our College Road campus. And we are naming the campus after our visionary founder as Padma Bhushan Dr. S.S. Badrinath Campus. Besides, a Tamil book titled Viligalil Uliyetram Shankar Nethralaya by Elangove and Dr. T.S.S. Sir is getting released today. I would like to introduce the speaker, Dr. Maneesh, who completed his DipNB in ophthalmology. I'd like to extend a warm welcome to our moderators, panel members, and we look forward to your expertise and insights. And we are grateful for your participation in today's discussion. As we come together today, I'm reminded of the shared experiences, memories, and bonds that unite us as alumni of Shankar Nethralaya, especially on this day, which is Steve's birthday. Whether we are near or far, the virtual platform offers us an opportunity to bridge the distance and reaffirm the strong ties that bind us together. So let us make most of this opportunity to learn from each other. Once again, a warm welcome to each one of you participating in this program. Thank you.
Thank you, ma'am. Now I'd like to invite Dr. Maneesh Bapaye to start his talk.
Good evening, everyone. At the outset, I would like to thank Dr. Shikha and all my teachers for giving me this opportunity on this auspicious day of our chief's birthday and a memorable day when his bust is being inaugurated today. I will be presenting. I have two presentations today. Well, first is a case of microspherophakia. This is a video which it has its the video has audio. I'll play it now.
Microspherophakia is a rare autosomal recessive condition characterized by small diameter and increased thickness of crystalline lens. It is associated with high myopia and glaucoma. Frequently, it is associated with syndromes like Weil-Marchesani's, Marfan's, and homocystinuria, etc. We present a case of a 34-year-old male patient who presented with high myopia and poor vision since childhood. He had very high myopia and poor best-corrected visual acuity. Clinical examination showed microspherophakia with dense nuclear sclerosis. Intraoperatively, partial thickness scleral flaps were made in horizontal meridia after limited conjunctival opening and marking with Agarwal marker.
It's a 8-minute video. After the video, we can discuss probably.
In majority of these patients, the lenses are soft due to young age of the patient. However, in this patient, for lens removal, we decided to perform phacoemulsification due to very dense nuclear sclerosis instead of lensectomy by posterior approach. Capsulorhexis was initiated using cystitome and completed using microcapsulorhexis forceps. Superior incision was taken. Gentle hydrodissection was done to avoid zonular stress. Nuclear rotation was very difficult due to relatively bulky nucleus in a small capsular bag. We used vitrectomy cutter to decompress the nucleus and achieve nucleus rotation easily. Vertical chop technique was used to divide the nucleus into smaller pieces. How dense the nuclear sclerosis is can be judged from the difficulty in cracking the nucleus. Each nucleus piece was emulsified after removing it from the capsular bag. 90% phaco power and 500 millimeter vacuum was used for nucleus removal. Vertical cleanup was done using bimanual cannuling. Capsular bag was left intact till this point of time. Gauge sclerotomies were made. Infusion cannula was fixed in infratemporal quadrant. The capsular bag was removed using vitrectomy cutter. The remnant of capsular tags were removed from CBM cells. Complete pars plana vitrectomy, including PVD induction and base excision, was done.
PVD was induced in different quadrants because it was a young patient. PVD was quite densely adherent.
Sclerotomies and scleral tunnels were made from partial scleral flaps already created. Key-piece IOL was injected in the eye and leading haptic was externalized using microcapsular axis forceps. The trailing haptic slipped while trying to grab with microcapsular axis forceps inside. It was retrieved with microcapsular axis forceps in right hand in using externalized leading haptic as fulcrum. The trailing haptic was externalized. Both haptics were tucked in the scleral tunnels. The cannulae were removed and sclerotomy sutured with 80 vicryl. The scleral flaps and conjunctiva was closed using fibrin glue. Patient had excellent visual outcome bilaterally. Right eye IOL was well centered, while the IOL in the left eye, though slightly decentered, did not cause any visual symptoms in normal sized pupil. In conclusion, Debulking the cortical material helps in achieving nuclear rotation. In these cases, should phacoemulsification be necessary, the IOL has to be iris supported or scleral fixated. Latter is our choice due to more predictable refractive outcomes. Thank you.
That was the case. Bilateral micropherophakia. Fortunately, this patient did not have angle closure glaucoma at presentation, or probably because of nuclear sclerosis, the lens did not really move anteriorly. But it was nevertheless pretty challenging to manage, because the choice was to do lensectomy versus phacoemulsification. And I chose to do phacoemulsification, and I think it worked pretty well. For anterior segment surgeons who can follow this technique, or who follow this technique, and they are good with iris fixation of IOL retrofixation of iris claw lens, I think they can leave the posterior capsule intact, and it acts as additional support or additional safety while putting the iris claw lens when the surgery is performed by anterior segment surgeons. So that was the idea behind demonstrating this case, that we can have very good outcomes in these patients. This glued IOL, or externalizing the haptics and fixing the IOL in sclera, is what I usually prefer to do. That's my modality of choice after trying different methods, and this is what I'm comfortable with. But however, other techniques can also be definitely used. And as taught by our teachers, whenever doing SFIL, always perform complete vitrectomy with base excision. And if there are any problems that has to be dealt, better to deal it on table than have a RD at later stage. So that was the whole the case about. So comments and discussion.
So Dr. Maneesh, what question I would like to ask you is, what for the anterior segment surgeon whenever they are performing a microspherophakia?
Request Dr. Kasi to mute. I don't know from where some background noise is coming.
Kasi has to mute his mic. I think something background and from a Kasi's signal you can make out.
Is it mine, sir?
Yeah. You'll have to mute it, Kasi.
Yes, Kasi.
Yeah.
So my question to you, Dr. Maneesh, was what would be your suggestions for performing a microspherophakia, the phacoemulsification? What are the steps that should be done for beginners who are here attending also?
I think doing phacoemulsification for such a dense cataract in microspherophakia is a very rare occurrence, because usually these patients might present with at much earlier stage than such a dense nuclear sclerosis. They present with high myopia. Nowadays, with school screening programs and everything, increased awareness, they will present much earlier, and we can treat these patients much earlier before doing this, before they go on to develop such dense cataracts. However, if you are planning to do phacoemulsification in such a case, I think the idea is to get a good capsulorhexis, large enough capsulorhexis, so that when you are removing the nuclear pieces from the capsular bag, you shouldn't have to struggle and cause zonular traction. That is one. And secondly, if required, you can use the cutter to debulk the nucleus. So you can get good nuclear rotation, and then then you can easily manage the phaco as a routine phaco case.
One thing at this point, since you brought the topic of phacoemulsification and microspherophakia, in the panel we have both the anterior segment and posterior segment surgeons. So my question to the anterior segment surgeons, I think Dr. Bhaskar's MD is there, and Mona is also around. Microspherophakia, if like Maneesh has done phacoemulsification, and after that he has done an SFIOL when the entire bag was there, would you why not put an intraocular lens if the bag is stable enough to take the force of phacoemulsification? It's not an easy surgery to do, unless the zonules are, you didn't even use CTR, you didn't require any support, which showed that the zonules were pretty robust. So why not put a lens in the bag? Why remove the entire thing? My question to the panel, anterior segment as well as the posterior, the entire panel.
I was about to ask the same, Maneesh. When you've done a good phacoemulsification with the rhexis intact, so why didn't you think about putting a CTR or capsular support, something like that, and put a lens in the bag rather than having an SFIOL?
Because this bag is way too small. You try to put a CTR, a normal size CTR, it's going to, this bag is not stretchable. This bag is going to break and it's not going to give us good support. Secondly, the zonules, even though I was able to manage it on table right now, these zonules might give way over a period of time. So one thing, you can definitely not put the lens in the bag. A normal size lens in such a small bag is going to lead to bag being lost, bag being broken on the table. That is one. Secondly, if you put 3-piece lens in the bag, in the sulcus, even there is a chance that you might, over a period of time, as the zonules give way, the lens might dislocate. So it's better to either put a iris fixated retro-iris fixation of claw lens or do a SFIOL, whatever is your modality of choice.
What was the size, Maneesh, of the, did you do any test, or something to check the size of the lens?
It was, I think, this case was done about 1.5 years back. But if I remember correctly, I think the bag size was about 8.5 to 9 millimeters. So
an Acrisoph could have easily gone. But it's like thinking out of the box. Convention says, microspherophakia, ideally you should go for an SFIOL, but you could do a phaco. You've shown a video that where you could do an uneventful, very comfortable phaco. You've rotated the nucleus well. But since you had the entire zonule and bag system intact, an Acrisoph would have gone in that, in that bag.
See, the problem that I have with Acrisoph 3-piece lens, MA60 AC lens.
Single piece. Why?
I have a feeling that it would have, the haptics would have folded way too much, and over a period of time, if this is a young patient, if the bag would fibrose over a period of time, it's not going to have good visual outcome in long run. It's not going to sustain that lens, and then if you have to try and then at later stage remove the IOL and put SFIL, so I thought it was better. I think the haptics.
That's one point. Way of. It's each one's experience that teaches. PB sir's comments on the case. PB sir is there.
Yeah, I thought you are allowing anti-segment surgeons to talk first.
No, I said anybody. Then later on, I thought you are anterior, posterior segment, everything. I've seen your phacos, sir.
No, basically, what Maneesh has mentioned, see, we are dealing with a different pathology. Here, zonule, there is no loss of zonule when you deal with a microspherophakia. These zonules are lax because of various pathology, various reasons. They are zonules. And lens basically is smaller. And because of lax zonule, lens become rounded. And it's quite a lot of fluctuation is there. Lens move back and forth. And that's the reason glaucoma, why you get a pupillary brow glaucoma, because typically small lens comes in a pupillary area and sits there. Okay. So ultimately, that's why you cannot put IOL in the bag. Yes, phaco, you can try. Most of the quite sometime it work out. If lens is soft, Yes, easily you can suck the lens matter. There's no issue. Probably sometimes you do not need phaco. They are also phaco energy. This is a rare case, was Maneesh said, because nucleus was hard. Generally, it is quite soft. And when in his commentary, he has mentioned that also. So basically, bag is unstable, and you want a stable lens, basically. That's the primary thing. So there's no question of putting lens in the bag. You can try, but whatever problems he has already mentioned. But just the sake of discussion, I think better sometimes you confuse the juniors. I think just don't give that option. I would put straightforward. That is one part. Second part is, now when Maneesh, I know he's a good surgeon. He can do very good phacos and vitrectomy. And he is doing good phaco because he knows, because if something goes wrong, he can handle if something goes down. Okay. So these are the lenses. Eventually, if you are planning SFIL, give an option, I would straight go ahead with lensectomy. And we have now fragmentomes are exceptionally good fragmentomes. Grade 3, grade 4 nuclear sclerosis can comfortably, you can manage with fragmentation. So I would like to minimize the manipulation in the antechamber corneal decompensation. It will be minimized. Okay. Yes, you need a 23 gauge sclerotomy if you want to do fragmentome, not 25. But otherwise, most of the part what he has done, yes, I agree again, back. And again, I would not in favor of keeping the capsular bag, even if a retro iris lens you want to fix, because this bag is going to crumple over a period of time. In fact, will cause more problems. So I'm in favor of always doing a clean job. Remove the bag, remove everything, put vitrectomy and scleral fixation. Of course, scleral fixation, various options are there. One he has shown, but depending on surgeon's comfort and preference, we can choose any option.
Thank you, sir. Very, very logical.
Can I?
Dr. MB's comments?
Yeah. So the thing is, these patients also have anti-segment abnormalities with iris abnormalities as well. So thinking about an iris claw lens or even sulcus IOLs is going to have its toll on the iris. So ultimately, the prevalence of glaucoma in these patients over long term is almost 50%, whether it is open or closed angle. So we would like the IOL to be in this natural position. I think the scleral fixated IOLs achieve that much better than anything else, except maybe one exception. If your bag is slightly larger than what Dr. Manish's case is there, probably you may think about putting a Sioni 12 model CTR and again scleral fixate it and then put the IOL. But then you need probably a customized IOL. I don't think that much of effort is needed when you have a good SF IOL technique is available. Other than that, I think the capsular phimosis, zonal laxity, all those are going against putting any other kind of IOLs, I think, because we are looking at young patients who need this kind of IOLs for long term. We are looking at 10, 20 years of, good centration and things, even though, of course, with SF IOL also that can happen, but better chances with SF IOLs with good techniques.
So now I have one question, like Dr. Maneesh, you said the capsular rhexis. So where would you start your capsular rhexis, especially in this microspherophakia? Because do you do an UPM prior to assess where the zonules are little lax, or where exactly would you position or start your capsular rhexis?
I do not have easy access to UBM, so I didn't really do any UBM in this patient either of the eyes. The thing is that I started I started it in the center, the rhexis, and then continued with microcapsular rhexis forceps. As I had already planned vitrectomy, I was not, I was not really worried about whether the rhexis would run out and it will lead to posterior capsular tear. If that happened, then I would have just done the lensectomy. But I was just trying to avoid having to deal with lens in the vitreous cavity close to retina, which I managed to do in this particular case. But the thing is, the idea is to get as large a rhexis as possible so that it doesn't when you are trying to, if you are going to do phaco, and if you have to pull out the nuclear pieces, don't try to emulsify the nucleus pieces in the capsular bag. It's not going to work very well, I think, in this case. We have to get it in the anterior chamber, and there you have to emulsify the pieces. So getting a good large rhexis is what is ideal. If you do not get it, then I think doing lensectomy is a fair game in this case. But I think such cases have to be done in association with VR surgeons and not try by anterior segment surgeons alone, because you can end up with unknowns while doing the case.
Right. One suggestion.
Shika, may I?
Yeah,
Hello.
Dr. Kasi is saying.
Yeah, please, Dr. Kasi, go ahead.
Yeah, Maneesh, I would also agree to that, because we are all VR surgeons. We know that doing a lensectomy is easier, but sometimes the small fragment which falls in the vitreous, being this an young patient, sometimes PVD injection is difficult, and sometimes the small pieces may get stuck to the posterior hyaloid face, and getting these smaller pieces in a lensectomy is more difficult rather than the bigger pieces. So given a choice, I would also try to do a phaco, and if it drops, because you are a VR surgeon who can also do phaco, if it drops, then lensectomy would be a choice. And nowadays 23 gauge vitrectomy lensectomy fragmentos are also available. So given a choice, I would have also started with a fragmento, with a phaco, and if it falls down, I would have changed to a fragmento. And second thing is the conjunctival opening, which I've seen in your case. You have made a large conjunctival opening, and the sclerotomies also need a suture to close it. So what I do in my practice is I make the localized conjunctival opening in the flap area alone, and my sclerotomies are still sutureless. They are transconjunctival. So larger opening, you have a good exposure. You can see nicely the flap, everything, because you're internalizing the external haptic. You are just railroading it to the Chariot's tunnel. So that is the reason you're having a big opening there. But sometimes what I do, I have just the opening on the flap, and then my choice of IOL off late is changed to CMT Flex, which is our own aluminous Nivean lenses, which I'm using it for the past more than 2-3 years, and more comfortable. There is no problem of pushing the haptics into the Chariot's tunnel and all. So what I would, one thing which I have modified is I have a limited conjunctival opening, so that the sclerotomies also become sutureless. And with the 23 gauge, again, it can be sutureless. It's just my choice. I'm not telling that's the best.
Yeah, so my logic in this is that anyway we are going to use glue and close the conjunctiva. So it's going to be sutureless and not very irritant to the patient. I like to suture my sclerotomies and sleep peacefully, because those sclerotomies leaking in a SFIOL, I'm little so again, it's different strokes for different folks.
Yeah,
so
it's a choice.
It's two different ways of thinking, I guess.
This point in time, actually, whether people do sutured IOL, sutureless IOL, or you would like to do an IOL which is placed in the iris, or all these techniques are like different techniques which can be followed, and if you are going to do it properly without much complication, I think that is what is required. So Mona, you wanted to say something.
Yeah. So as an anterior segment surgeon, I just want to add that if you are tempted to do phaco in such cases, so it's good to use a dispersive viscoelastic like viscoat, so that you have less chances of the fragments falling back into the vitreous. And also capsular hooks may be very helpful in case to stabilize the lens while doing the phacoemulsification. And of course, all the low parameters of the machine and the careful hydro and the vertical chop which was done. There are some case reports which say that they have put the IOL in the bag. That depends on the size of the bag which has been there. Like usually they say less than 7 is microspherophakia. So in case you have access to a UVM with, I know the zonular status and as well as the size, although there are reports, but again, where they have put the lens in the bag, single piece, foldable, and they have put a suture through the haptic and then with sterile fixation via the bag. That has also been reported. But again, later on, as we discussed, if the phimosis occurs, then you really don't know how it may hold long term. So what do you think about that? There are some case reports where they have done some series like that.
I think all these reports look very good. The videos look very good when done, but they rarely talk about what happens in over a period of 2 years, 3 years. And since these are young patients, capsular phimosis and the distortion of IOL are, I think, very much possible, and it should be kept in mind, I guess.
Actually, this answer should come from glaucoma department, Dr. MB and yourself, that if it is put in the bag, the logic that PB sir gave was that these bags are very mobile, and these can, over a period of time, because of the movement and all this, can increase the chances of glaucoma over a period of time. Is it?
So, these patients may have a pre-existing angle dysgenesis, that is one thing, or they may have had intermittent angle closure before the surgery, which would have caused synechiae. But once I think the SFIOL is done, the anterior chamber usually becomes quite deep. And the only thing which is there is a pseudophacodonosis, which is occurring if you put it in the bag. It may not occur if you're putting it a fixated IOL. So that is the advantage of a sterile fixation. So but if you put it in the bag, there will be, like in high myope, sometimes we see a deep AC and irido and phacodonosis despite everything being stable. And although pigment dispersion may not be that much, but usually on the long run, also, as long as the angle is open, I have not seen glaucoma develop unless, like, sometimes gas is put along with the SFIOL and then they have post-op AC shallowing. That could be a risk factor for glaucoma later on.
So if I ask for glaucoma opinion, that should I say I can put it in the bag, I can do a pick and put it in the bag. Would you, would you advise SFIOL will be patient from the glaucoma department?
From glaucoma point of view, I don't think either has
that the lens can be placed in the bag.
So if IOL will not dislocate forward. It will only deepen the AC. That's what I feel. Let's hear Dr. MB's comments also.
I predispose the eye to glaucoma in future. That's the simple question.
No, I don't think so.
Laxity may not be seen now, but with time it can happen. And if you are not fixating either the capsular tension ring or the IOL, whether it is going to be in the bag or in the sterile fixated area, it is going to start moving forward with the zonal laxity with time. It may not be seen now. And again, the choice of IOL, I'm again against the single piece IOL because it's very compliant. You may need to use, again, the bag size need to be considered. Okay, but this is a very, very rare situation where you may see a slightly larger bag, but not spherophakia, but micro still coming under moderate microspherophakia. And then you want to do this. You have to use something like a Sioni 2L ring where you have to fixate it, sterile fixate it, and then put it. It's a tedious procedure by itself. So somebody who is really well versed with it can try it. But I think it is a rare exceptional case. And when you have a good sterile fixation technique available, I think that is easy to take up with many VR surgeons in the country now available. So I think the choice of putting the 3-piece lens in the bag after doing the phacoemulsification in a slightly larger, bag with sterile fixated as, CPR, that is the only possibility that I can see. Other than that, I do not envisage just putting the intraocular lens inside and allowing it to have the donosis and causing a fusion, because the incidence or prevalence of glaucoma in these eyes are 50% with time. So I don't think it is very advisable to allow it to happen because many of them will have angle anomalies and zonal laxity with time.
Thank you.
I have a question for Dr. MB. So if there is a patient, how would the management differ in a patient who's having microspherophakia presenting with angle closure vis-a-vis a patient who's having a very intumescent lens and having phacomorphic glaucoma secondary with a normal lens size, how these two will be management would differ?
Well, I think you put it very simply, black or white, or there is a lot of gray in between.
Okay.
Because, whether it is angle anomaly present, whether there are peripheral anti-synechia present, whether the disc is normal or not, there is so many. And then, of course, if there is a syndromic presentation. So we need to consider all these factors into place. But the moment we suspect that, the disc is getting involved and the intraocular pressure is not under control, especially with angle closure, we may be thinking in terms of a combined procedure. Because in the long term, these patients are not going to do excellent with just medical management, unless, of course, we are continuously having a follow-up of these patients and we are seeing that there is, medically these patients are very well controlled with mild glaucomas, because these are very refractory glaucomas in due course. And then, we do see a problem. Of course, the choice of surgery might be different. You might want to do a tube implant rather than a trabeculectomy, because you're going to put in an intraocular lens in these eyes. And these are young patients. We don't want to leave them with the bleb. So the choice left alone, if it is going to be mild glaucoma, which is very well medically controlled, I would still go in with just the intraocular lens scleral fixation. Of course, we will bug you about the conjunctival closure part. And, we will keep the superior conjunctiva and the temporal conjunctiva, especially superior temporal conjunctiva, intact and go. Otherwise, if it's going to be moderate to severe type of glaucoma, especially with angle closure type, we might have to do a combined procedure. Again, we would be preferring in a VR setup, scleral fixated IOL with, a combined procedure, because these are, not just the elegant part of it, it is the most physiological that I would say. And ultimately, the glaucoma surgeries also will do well. We will have enough space in the sulcus to put in a tube. So I think that's how we manage. So the choice of doing glaucoma surgery comes when it is moderate and beyond, and intraocular pressure is not under control, and when the disc is involved. Have I answered? Yeah.
Thank you.
Thank you.
So that
we'll move to the second.
Yeah, one second. It was a good point which Dr. MBS brought in. Like he said, syndromic patients versus non-syndromic patients. So I have one question to Dr. Chetan Rao, who is here. So Dr. CR, you're there?
I'm there, you can see me.
Yeah, so good. So the question to you is like, when we do SFIOL as an isolated procedure, versus an SFIOL with a combined procedure, like for instance, a trab. What are the complications you tend to see in the post-operative period?
See, all the complications are mostly due to your bad handling of conjunctiva and the wound closures. Otherwise, I don't really... So again, nowadays people, if they want to do a trab, along with that, they would probably use the technique that Maneesh has just shown. Putting a foldable lens and using those tunnels to put it. So if you have to make a scleral flap, open the conjunctiva, do the conventional surgery where you put the rigid SFIL, that means you need to open, you may have to open you may have to make a trab, large flap, extend that to put the IOL. So basically the ultimate problem is you should have a very good wound, and the conjunctiva has to be spared, the way Dr. Bhaskaran was saying. Otherwise, you will end up with you may have a good SFIL and everything great, but the trab will fail. Conjunctival scarring has occurred. It's not really functioning well. But fortunately, if you do a good vitrectomy in those cases, as Maneesh is saying, like we all do, that somehow helps in keeping everything open. If you leave behind a lot of vitreous and stuff like that, and it becomes worse. Whatever you have done, it won't work. Whether you do a trab, whether you do a tube, nothing will work.
So what is your experience on IOL decentration or on IOL tilting in SFIOL patients?
No, if you have scleral fixated this way, it doesn't tilt so much. And even 10-degree tilt is sufficient. It's manageable. 10-degree tilt can be, a patient can tolerate 10-degree tilt. That's not a problem. Most of the IOLs will have a little tilt here and there. But if it is fixed properly, the sclera, very unlikely. Of course, the one that Maneesh was talking about, the one where you fix it with the haptic, those, yeah, if your skill tunnels are not tight enough and the haptic has been slightly modified because of holding it, then yes, you can have a little bit of decentration. But in general, nowadays the very tight tunnels are there. So, and the IOLs, again, it depends on the IOL that you use. So if you're using the sensor 3-piece IOLs, these are really where the PMM IOLs, they are a little brittle. Sometimes you get kinks when you hold it hard. So you need to have the right forceps to hold it and pull it gently. And like Maneesh was showing, you really should not mishandle the haptics too much. Just hold it once, grasp it and bring it out. Too many manipulations of the grasping of the IOL haptic is going to cause a kinked IOL, haptic, which leads to some amount of decentration.
Thank you for those valid inputs. Now I think we'll move on into the next presentation by Dr. Maneesh.
I'll
GSMM, this is Dr. Nagesh from Bangalore. I have a small comment about this SFRs. Can I share that?
Yes, yeah, Nagesh, please go ahead.
Of late, I'm doing the both techniques, the glue technique and the suture techniques for many of my cases. Regarding the tilt or the decentration do happens, especially with, when you are touching the haptics into the sclera. Either you are doing a GABA shader technique, the original technique, or whether you're doing the glued, the modified one, that is Agarwal's modified one technique. The decentration do happens when you are pulling too much of your haptics and then plugging into the scleral tunnels. But tilt may not happen in those cases. Tilt in the scleral fixated SFRs, especially when you're suturing it, do happens for two reasons. One reason is when we are passing the thread into the eyelids of the haptics, that is PMMA lenses. Sometimes we may confuse and we pass the needle from upside to down or from above to below on both the ends. That can cause a tilt. Usually we it's not forget to pass one thread from above to below and another thread from below to above. That will balance on either side at 3 and 9 o'clock position. The second problem I saw the tilt in SFRs, especially the suture SFRs, is remnants of the capsular bag that is left over at 3 and 9 o'clock position. Often the pupils will be mid-dilated. We may not be able to appreciate those fibrous capsules which are there itself. That can cause the haptic ends to tilt at the ciliary sulcus. That means the curvature of the haptics is not sitting in the ciliary sulcus. Rather, part of, or especially the tip of the haptics might have slipped away from the ciliary sulcus because of the contracted tough membranes that is sitting at the ciliary sulcus area. And once we can able to clear that part, I think most of these suture SFRs will have zero tilt back in those cases. This is an observation I have made it over a period of time, madam. Thank you.
Yeah, now Dr. Maneesh, you can start your next case presentation.
Okay. So next case is it's about management of subconjunctival silicone oil, which we don't really face very commonly. But when it is there, it can be a problematic situation. And I had one such case, which I would like to share. So, sorry, the slides are not moving. Yeah, okay. Okay, so silicone oil, as we know, has been used in VR surgery since 1960s. And though Dr. Seves started the use of silicone oil in non-vitrectomized eye, it was Dr. Zivojinovic who used it as internal tamponading agent after pars plana vitrectomy. The more frequently and more serious complications that we see are emulsification, cataract formation, secondary glaucoma, and keratopathy. However, subconjunctival leakage of silicone oil is slightly uncommon. However, nowadays we see it more frequently in era of sutureless vitrectomy. So this was a patient who was a 54-year-old male who had undergone vitrectomy with gas injection for reg RD. He was noted to have inferior recurrence after the with PVR 6 weeks post-op after the gas started getting absorbed. Then I took him up for revitrectomy with reattachment, and silicone oil injection was done. But the patient came back with progressive congestion and persistent ocular irritation and mild multiple conjunctival cyst formations. There was, we noticed that there was a breakage of a suture in supranasal quadrant sclerotomy, which led to subconjunctival silicone oil leakage. The patient was treated initially with symptomatic treatment, and then SOR was planned along with subconjunctival oil removal 4 months post-op. So the video is that of management of subconjunctival silicone oil. Initially, I tried to do limited opening, but then I realized the cysts were way too multiple. So I went ahead and did 360-degree peritomy with opening of so as to get proper exposure, because as we can see, the cysts were there going well into the fornicial area. And there was a lot of conjunctival scarring. So putting the conjunctiva back would have been a problem. So getting a proper opening was necessary. There was a very large cyst in the inferotemporal quadrant. And as I started dissecting, I could see that I could dissect between the conjunctiva and the cyst wall. And then you can see the oil globule being expressed. Then the area where we have to expose the conjunctiva properly, these cysts may form on the bulbar side as well as on the conjunctival side. So we have to very patiently keep dissecting the cyst. I switched over to Vanna scissors so that I could dissect the tenon cysts without affecting the, without causing any scleral trauma, minimizing the scleral trauma. And so all this, each cyst, it's kind of satisfying. It's like, you know, bursting bubble wrap, but it's a tedious process. We need to keep doing it in various multiple quadrants. Even on the conjunctival side, we have to keep dissecting. And when we are doing this, we have to be very careful not to create any conjunctival buttonhole, because then it's going to complicate the closure at later date. So there is definite boundary between the cyst wall and the conjunctiva where we can get a good dissection. Here we can see one such cyst, which is dissected out of the out from the conjunctival wall. And once at the end of the surgery, again the fibrin glue was used so that I could get a good closure, and without putting suture again would have been problematic, because patient would have ended up with a little bit more irritable red eye, congested eye. So I wanted to minimize it, hence the fibrin glue was used for conjunctival closure at the end of the procedure. So this was 2 weeks post-operatively slit lamp photo. Here we can see the cysts are gone by and large. There are very few cysts which we can see in the inferior part close to the limbus, but the patient is far more comfortable. I had put in gas again just to avoid having recurrence after doing laser, because patient was a bit of a VIP patient. So coming to discussion, I think the discussion has to, we must start the discussion by this paper, which is published 25 years back by JB sir and PB sir, LG sir, Dr. Sunil Parikh and Chief. And this is one of the earliest publication which described the histopathology of subconjunctival silicone oil, which was done by JB sir. So the cysts that they have dissected, grossly there is white translucent to grayish brown uni and multilocular cysts which are present, while microscopically we can see the engulfed silicone oil bubbles which are surrounded by fibrocollagenous tissue, which is infiltrated by chronic inflammatory cells. So basically, even though silicone oil is generally considered to be inert, it can stimulate inflammatory response when it leaks out of the eye. The causes of this happening nowadays are with sutureless sclerotomies, or if the suture breaks, as in my case. It is also seen after because of scleral thinning following multiple VR surgeries. Most of the cases which are described in literature are after second or third surgery where the patient has leakage. The paper that I described before from SN also had 5 patients, and most of whom had multiple VR surgeries, and they had this subconjunctival oil leakage. So the patient may be asymptomatic and he may have it will be more of a cosmetic problem rather than having any symptoms. But there can be variable degree of conjunctival congestion and scarring. The giant papillary conjunctivitis has been described, and even leakage of oil into orbit causing displacement of the globe and mechanical ptosis because of leakage into lid tissue has been described, where they have actually gone ahead and opened the lid to remove the oil bubbles. So this is one such paper from retina where we can see these multiple small globules, and the OCT where we can see the anterior segment OCT at various points where we see these multilocular cysts which are present in conjunctival and subconjunctival and Tenon space. I believe there is one such image is there on cover of Eye, and which is taken by Dr. Kushal, who was a ex-SN fellow. This is another presentation where the patient has got giant papillary conjunctivitis. We can see inflammatory cells which are there in the fibrocollagenous tissue surrounding these cysts. So to conclude, the subconjunctival silicone oil should be avoided by using sutures, even if you are doing MIVS. My go-to technique is usually I open the conjunctiva, suture the sclerotomy when I'm injecting oil, and then put the conjunctiva back like we used to do with 20 gauge sclerotomies. The patient may not have symptoms, but if symptoms can be very severe, like in my patient, we may need surgical management, and if needed, we have to dissect the Tenon cysts from overlying conjunctiva, making sure that we are not creating any conjunctival buttonhole when we are removing these cysts. So thank you for that.
That was an excellent result, actually, what you have shown, but otherwise, the subconjunctival silicone oils are not only a nuisance, but the patient finds it cosmetically disfiguring also. So I would like to request PB sir, because that was his article which was pointed out as the first article. PB sir?
Yeah, I'm here very much. I'm listening quietly.
Yes, sir. So we would like to know, how do you manage your subconjunctival silicone oil? Because we all know that these are granulomatous inflammatory response which is there. So how do you manage cases, sir?
Yeah, basically it's a very, very low grade inflammation. What he has rightly mentioned is histopathology. And all these cysts are encapsulated. Very nice capsule you get. And most of the time, patient complain for symptomatic cosmetic reason, not otherwise. And very rarely, if cyst is large enough, then mechanical restriction it can cause. Otherwise, if the small cyst generally does not cause much problem. Patient, most of them, though I look congested, but generally patient doesn't complain about it. Okay. So patient is asymptomatic, probably I would leave him. But if it's obviously they have a concern about cosmesis. Cysts are sometimes so large, also cause a mechanical hindrance. Sometimes they even cannot close eye properly. In that situation, obviously you need to remove. And what Maneesh has showed is something like Maneesh said is very satisfying, because something you have bubble wrap and you want to just burst those bubble each one after another, and you feel nice that okay, you get that sound. But that's one way of doing it. But what you can do is, and that last cyst what he shows, this cyst, as I said, nicely encapsulated. You can comfortably, yes, you need to have a little bit more meticulous, spend more time, and particularly where so many cysts what he has, nobody would do that. Each and every cyst can be isolated, nicely dissected out without damaging conjunctiva or damaging sclera. And that's what all those cysts were sent for histopathology. So what Dr. JB has done subsequently, and incidence actually is much higher. Is underreported rather, because small cyst here and there, nobody really bother about it, nobody reports about it. Incidence is high. What is more important is what Maneesh said eventually, like even though MIBS, I would say is when you're using silicone oil, definitely see a close suture the sclerotomy. Also, even we have seen the cysts in eyes where those who are underwent SOR. So leaving open conjunctiva, and if you have oil coming out and those some droplets here and there, go close conjunctiva over it, that also later on can come back with those isolated, like loculated cysts. Best ways, that's why we thoroughly irrigate the eye. If conjunctiva is already open, definitely would have a thorough wash, whether you remove the oil, whether you use, of course, most of the time silicone oil removal, you are not opening conjunctiva nowadays, but previously you used to do that. But ensure you give a thorough wash before closing conjunctiva, if at all you open it. And yes, suturing the sclerotomy, irrespective of whichever gaze you use.
And I think one more point is to maintain a normal IOP when we close the sclerotomies. If it is on a higher side, then you will probably have a leakage to the post-operative fluid also.
May I? Because
yes, ma'am.
Yeah, I think very often when we take that transconjunctival sclerotomy suture, which we do very often in MIBS, that transconjunctival sclerotomy may end up being just a conjunctival sclerotomy and not exactly through the sclera. So those are cases also where you can have leakage of oil.
That is what Maneesh wants to open the conjunctiva and suture. I think that's a good way of putting good point.
Yeah. One thing is this is more common because we reuse the instruments. We don't have a single use, and this is more common now. So what I do to prevent this subconjunctival oil in my surgery is, what I do is, before when I remove the sclerotomy, what I do two things. Before I remove the sclerostomy for oil injection, what I do is I reduce the speculum, that is tightness of the speculum. That will sort of reduce the pressure, intraocular pressure to some extent. So that is one thing I do, I reduce the speculum. And the second thing is, what I do is when I remove the sclerostomy, and after I remove it, I use because there is a lip, there is a biplanar incision. The anterior lip I always iron out with the forceps, so that it approximates and there is no subconjunctival oil leakage, microbial. So these two things I adapt to avoid this subconjunctival oil migration. One, reducing the sclerostomy, what is the speculum, and the second thing is ironing out the anterior lip of the sclerotomy. With these two things I do that routinely in all my sclerotomy injection cases. I don't suture it, but these are the two things I practice, and fortunately I didn't have much of subconjunctival silicone globules.
One question to PB.
It's a very time-consuming process. This case almost took me 40 minutes just to clear the oil bubbles, so it has to be done patiently.
No, you did a great job, Maneesh. I'm sure that it was. It made a huge difference to the patient's cosmesis. There were quite a few cysts there. One question to PB, sir. You've seen cases of posterior migration of silicone oil, sir. Somewhere, what Maneesh has shown is the anterior cysts. Has anyone in the panel seen posterior migration of silicone oil? And would it be as benign as this?
No, this is posterior migration. Very typically you see in a trauma cases where you have posterior perforation. Okay, those are the cases where dehiscence is there, and that can create a problem then. And you can have oil in an orbit also. That is one. And depending on quantity, of course, how much you have, then mechanical restriction or can have inflammatory response there. Of course, again, low-grade inflammation, but more like a mechanical response. And we have seen that now histopathology also proved cadaver oil migrates to the optic nerve as well. That's another issue. Okay, and gone far behind also. People have shown those published reports are there for that as well. Okay, but what we, as a VR surgeon, and if no posterior scleral dehiscence, most of the time what we face is what Maneesh has shown. Most of the time it is anterior. Because what happened, again, we are not opening conjunctiva nowadays. So previously, yes, we have opened the conjunctiva, you added the buccal, and then you inject silicone oil. So entire subtenon space is open there. and this oil just goes down. So that's why we make a point, you wash thoroughly, irrigate entire subtenant space, ensure all the oil, and see, it is easier to wash it because as the fluid jet goes in, oil floats on the fluid. So naturally it starts coming out on its own. So cleaning it is not a big job there. But yes, but we have to consciously do that if you have open conjunctiva 360-degree or particular quadrants, that and particularly adding buckling or scleral buckling or encircling band, either way is okay. And those bubble can then settle posteriorly. But those are generally very small and generally they won't cause. Issue is we have cases where have a trauma, posterior dehiscence, you assume it is sealed, and then once you feel the oil, you see few days later or months later, there's hardly any oil in the vitreous cavity or small, and most of the thing has migrated through that posterior dehiscence.
So I remember seeing one patient who was getting, they were oil bubbles cysts next to the optic nerve. It was that much behind, and it was causing a progressive decrease in vision. There was quite a bit of inflammation. There was the patient developed kind of proptosis. As it is, he was a high myope, and there was significant oil behind. There wasn't exact history of trauma though in that patient, but there were lots of these cysts behind and almost around the optic nerve. Not only, he was complaining of a progressive decrease in vision, fields was constricting, and there wasn't any way to actually reach and relieve the patient.
There is a case report, I think a case reported by Dr. Unni Nair, where they have shown posterior migration of oil into the cranium, into the around the chiasm. So they had to do neurosurgery to remove that oil from the intracranial space. The posterior migration has been reported where it can go into CSF. And
I agree with you. And then I think some neurosurgery conference, I think some video also has shown that they are washing out silicone oil. So I agree with you. Okay. And apart from that, not exactly related, because we think silicone oil is innocuous, not really causing much problem, and inert. We realize with time now, longer the duration silicone oil is, we are seeing more and more problems, some degenerative changes, some whether it's toxicity or degenerative changes or pressure effect, we do not know, but definitely some long-term effect on the retina also and also optic nerve.
Any comments? Dr. Casey is there with us. Any comments? Ekta is there. Ekta, please, instead of putting in the chat, join. And
hello, thank you, Shika. Can I just say something pertaining to the earlier case that you raised? A particularly interesting thing about doing phaco on that patient, because the zonule, as you said, the zonule seemed rather strong. What Dr. Mona said was also very informative, that you do low fluidics, lot of dispersive to keep the vitreous back. And just one more thing is, when you enter and leave the eye, you got to, with a non-dominant hand, inject dispersive, so you keep the vitreous back and don't allow it to come forward. And another point is, while removing the cortex, tangential forces rather than radial forces to lessen the stress on the zonules, and direct chop as opposed to divide and conquer. And another point is about rexis, whether femto rexis would be a thing with something to consider for this, because that is the least traumatic on the zonules.
And that's a good idea. I didn't have access then for femtorexis, but next time a patient comes, maybe I'll try that. I'll convince patients for that.
And the nucleotomy also can be done with that the same procedure with the least trauma, I think, isn't it? And what Dr. Suguneshwari was saying about raising the rexis, where do you raise it? Depends on if there is slightly subluxated lens, then you initiate towards the side of this, the subluxation rather than away from it, the initiation. And sometimes you may not get it all in one go. So you go step by step and then keep putting the iris retractors or the capsule hooks. You keep putting it quadrant by quadrant as you're proceeding. You insert those hooks as you proceed, and that keeps the zonule stress-free. That's all I wanted to say.
Thank you. There are very interesting comments from Dr. Ekta. She's saying puncturing with 30 gauge needle. You mean, I mean, like from outside or after opening? Dr. Ekta, you're there?
OPD basis we do.
Hi, Shikha.
30 gauge needle.
Hi, Shikha. Yes, sometimes when we are taking these patients for silicone oil removal and I'm not planning to do a full conjunctival opening since I want to maintain the integrity, and it often leads to a lot of surface abnormalities later, the 360-degree opening of conjunctiva. So just a small puncture in the cyst with a 30-gauge needle transconjunctival allows the oil to come out. And they heal pretty well. There's hardly any manipulation in that. Since these are more of, it's not conjunctival, it's more in the lower part, which is a cyst and more fibrous, so opening helps.
Yeah, I think this is valid when we are dealing with few cysts, 1 or 2 cysts which are there. But the kind of cysts I had, I think I had no option but to do a complete opening and remove it.
Yeah, you managed well.
Okay, thank you. Slightly, Dr. MB had a point about silicone oil. So,
Dr. MB, please.
And Maneesh, your actual silicone oil removal would have been much shorter than this, I guess.
Yeah, the whole case lasted about 65 minutes. 40 minutes was this. So.
Yeah, I think I have put it in the comment there. Basically, we do see some residual oil coming in patients with tube implants or trap, but that kind of transcends into the subconjunctival space as well. So we are probably inducing it. But the menace is it does cause low-grade inflammation and fibrosis in the long run. And we try to, it goes back and forth between the VR surgeons and us, we insisting that, we need a wet lavage or a AC lavage, whatever. But only in cases, very rare cases, we end up doing that because of the other impending complications with it. So, very rarely we do see any intervention is needed unless it is obstructing the tube itself and causing failure. But we do see this kind of subconjunctival migration with our intervention like TRAB or AGE. Yeah.
So I think now we are well ahead of time. So I would call Dr. Mona to give the concluding remarks after such a wonderful, very nice presentation which we've had. So Mona, you can, yes, your points of concluding remarks.
Before Dr. Mona, I think I would just like to say a few words. When Dr. Shikha called me, I was wondering as to what I can present, because it's the private practice day to day. We really don't do anything different. So this subconjunctival silicone oil, I did not think it would stimulate a lot of discussion, but it did, and I'm happy it was something offbeat, something different than routine VR work that I chose to speak about. I hope it wasn't too boring for everybody else, but it was an interesting case that I had to deal with. So that was the reason that I chose this case.
It was a wonderful presentation. Actually, it is something very important which we should all pay attention to. Both the cases were really, really very nice.
Request everyone to just switch on their cameras. No, I want us to this picture.
So I'll start to summarize meantime.
Yes.
So for the first case, thank you, Dr. Maneesh, for the excellent cases and the excellent discussion we had. So what we came to know is managing microspherophakia is definitely challenging. Although lensectomy is possible with the new instruments, if you are tempted to do phacoemulsification, you need to do it keeping, of course, the VR backup. or biobia surgeon, plus all the precautions we have discussed, like the low parameters and all the precautions to avoid any fragments from falling back or the capsular excess from tearing. And for the IOL part, the fixed IOL is definitely preferable. SFIL, the issue can be tilting, which can be due to capsular remnants, which should be removed. And glaucoma can occur due to pre-existing causes or coexisting causes or angle closure. Pre-op, of course, many patients may have a PI. VR surgeons are requested to please close the conjunctiva carefully. And regarding the second case, very, very interesting. Subconjunctival silicone oil can be asymptomatic, or it can be cosmetically disfiguring, or can cause symptoms from giant papillary conjunctivitis to even migration to the optic chiasma. And to avoid it, a good wash and a good closure of the ports is definitely recommended. And to remove it, either you can aspirate it, or you can be very, very patient and dissect each cyst, finding a nice plane between the conjunctiva and the tenons, keeping it no buttonholing of the conjunctiva. And these are very good take-home messages for all of us. So I thank you all for being a part of the academic tribute to our beloved chief. I thank Dr. SRB and Dr. Subneshwari for organizing very thoughtfully today's discussion. Dr. Sheila John ma'am, who's one of the best cataract surgeons and teachers, to being here. And PB sir and MPB ma'am for their wonderful insights from so many years of experience. Dr. MB sir for his excellent comments. And of course, Dr. Anand for his practical points. And of course, Dr. Maneesh for his challenging cases. And all the participants for being here today on this special day and for making it even more memorable. And also a big shout out to Astha and also to the multimedia team. Please do continue to contact us for future discussions. If you have interesting cases, we'll have it monthly. And we hope to see you next month with another interesting session. And over to Dr. Shikha now. Ma'am, you're muted.
You're muted.
You're muted.
Cameras on, please. Cameras on. Like I haven't made a picture.
No, Dr. Kasinathan and Dr. Chetan Rao also for being here today and offering such valuable insights.
Yes, Doctor. Yes, absolutely. And Dr. Ekta also.
Yes.
It's a pleasure to be on the academic front. Thank you. Thanks, SN, for giving me an opportunity.
Thank you, Shikha, Paula, and Suganeshwari for your wonderful arrangements.
Yes, it was really nice listening to everybody. And thanks, Maneesh, for sharing 2 cases. Thank you, everyone.
All my pleasure.
Thank you very much.
Good night. Thank you, PB sir, and thank you. Good night.
Good night.
Thank you.